good afternoon and welcome to our webinar, Ensuring Health Security, How Primary Care Can Strengthen Health Resilience. And you can already guess it from the title. We are taking a little bit of a wider look at primary healthcare, how it relates to health security and health systems resilience. And I think this is a very timely look because it was just yesterday in the news that 20 countries asked the European Union to prepare for climate change health hazard. So a serious issue. More than 60,000 people estimated died this year from the heat wave. And of course, we are not only talking about environmental shocks. We just had a pandemic. There's a looming economic crisis. And in Europe, we have very severe conflicts with wars raging in the region. So very important to see how primary healthcare actually can prevent and protect us from these shocks, but also health system resilience, very related to it. How can actually health systems absorb these shocks? And when we talk about this, you know, the connection between primary healthcare, health security, and health systems resilience, very much in the center is the connection and the linkages between primary care and public health. How do they work together? How can they interact? How can they strengthen the health systems? And also, of course, multidisciplinary teams, teams that not only work in the health system, but can reach out to communities, to public health. And last but not least, we all know resilience depends to a certain degree actually on trust and serious information and communication. And to tackle these topics, we have today a wonderful panel, but first of all, our keynote speaker is my esteemed colleague, Juliane Winkelmann. Juliane was on the team of this very important forthcoming book on primary care. It's called Implementing the Primary Healthcare Approach, a primer. And of course, some of what we discussed today will be based on it. And I can't wait to hear Juliane's presentation. But before we go to Juliane, I would like to introduce our excellent panel of speakers. We have Zlatan Memedovic from the Ministry of Health of Macedonia, and he will focus actually on transforming the health systems towards a strong primary healthcare approach. We have Sara Calderón from Queen Mary University of London. She will have a spotlight on Spain, zooming in on the health workforce and in particular, how teams can work together. And last but not least, I'm very happy to say that we have with us today Tom Rausch from the Ministry of Health from Luxembourg, and he will focus on primary care and trust and communication, how to establish trust. And just a little bit of a reminder, it's a very important topic, and you may have heard that in December there will be a WHO conference, a health systems conference, the Talent Conference, which is focusing on trust and transformation. And we are very keen to hear from Tom and see what we can learn from the Luxembourg experience. Okay, so much about the contents, just a couple of things on the housekeeping. Please use the chat for your questions, your comments, your ideas, but also if you want to share a document, that's absolutely possible. And the questions, your input in the chat will not be lost. We have at the end of the session today a panel discussion, and we will feed back this your input to the speakers. We are going to record this session, and you will find it in a couple of days on our YouTube channel. So that's about it for the introduction. And now I would like to ask my colleague Erika to present the participant poll. Erika, floor is yours.
Thank you very much, Matthias. Okay, so just a little bit of background from you would be really, really helpful. So a couple of questions in our poll. Firstly, during the COVID-19 pandemic, did primary healthcare contribute to health security in your country? And that's a yes, no, don't know question. And then the second question is, in your country, does primary healthcare strengthen health system resilience through any of the following? So through the integration of public health and primary care, through remote care, through multidisciplinary teamwork and new roles for health workers, through the transformation of modes of care and primary care outreach, through the involvement of communities and multiple actors, or indeed none of the above. Okay, look forward to hearing from you in the poll. Thank you very much. Back to you, Matthias.
Thank you so much, Erica, and I'm quite curious to hear about the results. But before we dive into the results, it's my great pleasure to announce Juliane Winkelmann, who will give us today the overview presentation on the topic. Juliane, floor is all yours.
So I'm going to present, give you a very short overview of how primary healthcare can strengthen health system resilience. And this presentation is partly based on a chapter on this topic, PHC and resilience, which is in the primary healthcare primer, a forthcoming publication which we launched. A conference copy was launched last month in Astana during the PHC conference, large international conference. And I acknowledge the authors of this chapter, Sara Allen, Miguel Gonzalez Plog, and Emily Vargas, who wrote the chapter and contributed also to the presentation. So just before showing and demonstrating the importance of primary healthcare for health system resilience, I just want to give a short introduction of the concept. So the definition of what do we understand by primary healthcare and also resilience. So primary healthcare is a very important vision of the WHO and is defined as a whole society approach to health that tries to maximize health and well-being by focusing on people's needs and preferences as early as possible and along a large continuum of care ranging from prevention, from health promotion, but also rehabilitation, and tries to be as close, deliver care and as close as possible. And it's composed of three components. The first and the most important, the foundation of this approach is the primary care and essential public health as the core of integrated health services. This is the entry point, but then the PHC concept or approach extends beyond this service delivery aspect and outlines an approach for the whole. It's like a philosophy of the whole system or a vision of the whole health system, and it recognizes the importance of sectors beyond health in addressing the broader determinants of health through multi-sectoral policy and action, the blue side of this triangle, and it is based on evidence-informed policies. And on the right side, you can see the red part of the ball or triangles. PHC really seeks to empower individuals, families, but also communities. It reaches out to communities and empowers individuals to take care and to control their own health, to engage as advocates of their own health, and to participate in multi-sectoral action for health. So far, to just give you an introduction of what is actually the PHC approach. And then just going now to the concept of health system resilience. It usually refers to the ability of health systems to anticipate, adapt, and respond to shocks. It can be shocks like the COVID pandemic. We have learned a lot of lessons. I'm going to back to these lessons learned in my presentations, but can also be, as Matthias said, economic shocks, environmental shocks, which we are seeing more and more, but also conflicts. So it really, this concept describes the, how characteristics that minimizes the negative consequences of disruption and how to learn from these experiences to build better and to strengthen health systems. Just now I want to bring those two concepts together and to show with the example of the COVID pandemic, how important the PHC was, primary healthcare was, and which lessons we learned. And so mostly the COVID pandemic prompted a lot of rapid adaptation, and mainly in primary care, and it showed the essential role for health systems as many flexible patient pathways and outreach intervention were set up. Primary care providers were most often in the first line of defense. They delivered essential and continuous care and also provided context-specific risk communication. And very importantly, I think the COVID pandemic really stipulated a rethinking of care in primary care settings should be delivered, and also showed the importance of remote care and digital solutions. But it also enabled access to care and services for vulnerable people, for example, through outreach. And During and after the pandemic, many European countries invested in primary care, but also in the digitalization. So it really created a shift of thinking. Health systems really learned that PHC is essential for health system resilience. It plays an important role both before, during, and after health emergencies or shocks. And the Observatory published a study on the strategy, on the lessons learned to build better, and on how countries can really enhance resilience. And you can see that many of these strategies relate and are embedded in primary care and are in line with the principles of PHC, which I presented in the beginning, in particular, the involvement of actors from different sectors, but also integration of public health and primary care. And in particular, COVID showed that having a strong public health and primary care system was really an advantage, and was in particular also when there was a tradition of public health, primary care, and community linkages. Just now to go a bit further and deeper into this, to show how really primary care can contribute to health system resilience, I'm going to outline 3 of these different ways. So I mentioned transformation of models of care and flexible patient pathways, and I'm going to talk about the 3 ways in the middle: the workforce, the role of workforce, and the expansion of access through virtual care and involvement of communities. So the role of the multi-professional health workforce was really important to build resilient multidisciplinary teams were set up to manage COVID patients in many countries. Managers and social COVID managers, social workers, and other professionals were added to existing primary care teams to manage dual track services. And in general, multidisciplinary teams are a very important contributor to health system resilience, as they have the appropriate skills and scope of practice to deliver comprehensive, preventive, and patient-centered care through a long-term community relationships. And of course, the COVID experience and other shocks, they show that the importance of the expanding the scope of practice of professionals and to do task shifting. One example are community pharmacists, but also the role of community health workers was shown during various shocks. So they support emergency response by communicating to the public in ways that the public can really understand and is appropriate. Secondly, the technical solutions played an important role and are important to maintain essential services in particular and create new pathways of care. In the European Union, about 40% of physicians provided or 40% received provided remote care via virtual channels, but also health digital solutions, they have the advantage to increase access to care, but also essential drugs, for example, electronic prescriptions, and they enable patients to really become more proactive and, for example, through online symptom self-checking tools. But of course, there are limitations to digital solutions in regard to in regard to technical issues, but there are equity concerns and digital literature issues, but also they only apply to a subset of care where in-person visit or treatment is not necessary or essential. And last but not least, the community engagement is part of the PHC concept, and it shows, it really contributes by building trust, which is important for having a resilient health systems. In particular, civil society and community groups, they are during the COVID pandemic, they were active in mediating between communities and governments. They provided and disseminated information. They offered social support or supplied personal protective equipment. So community engagement really enhances the adaptability of health systems, builds trust, and reduces inequalities as vulnerable groups are not forgotten. So last but not least, just to conclude, primary healthcare is really one of the cornerstone of people-centered and resilient health systems. New models of care, such as providing more care at home, investing in primary healthcare, and introducing community diagnostic hubs, are important and were introduced during the COVID pandemic. And as I said, multidisciplinary teams and digital solutions were and are important for emergency response. And last but not least, I think PhD is really an important driver and for promoting and creating innovations for health systems, and thereby they are continuously adapting, a driver for continuously adaptation of health systems, and therefore strengthen resilience. Thank you very much. I hand over to Matthias.
Thank you so much, Juliane. Was a great presentation. And, usually we are talking about primary healthcare in terms of access, efficiency, patient-centeredness, but you made very clear, actually, it's more than this primary healthcare. It has a very distinct role when it comes to health security and resilience. And actually, it's a very important argument also for the investment in primary healthcare, that we need to strengthen this, that we need to put resources, human resources, facilities at primary healthcare, and you pointed at 3 models of care: multi-professional teams and community engagement and trust. And I'm sure we will hear from the spotlight speakers quite a lot of interesting developments from their countries. But before we go to the spotlight speakers, Erika, can I ask you to present the results of the poll and comment them a little bit? Thank you so much.
Thank you very much. Yes, very interesting poll results. Really, nearly all of the respondents have said that, yes, the COVID-19 pandemic, did contribute to it during the COVID-19 pandemic. Primary healthcare did contribute to health security in their country. But interestingly, very evenly split through the various different ways in which it could contribute to health system strengthening. So although multidisciplinary teamwork was the forerunner, really all of the above was by far the all of these areas contributed in some way, which is quite interesting. I thought there would be a couple that stood out a lot more. So that's very interesting. Thank you everyone for your responses. Back to you, Matthias.
Thanks, Erika. And actually quite reassuring and encouraging, because it looks like we've learned a little bit of the lesson from COVID-19, how important primary healthcare is for health security and resilience. And now it's my great pleasure to invite Zlate to take the floor and to tell about Macedonia. And I know the country is currently undergoing very substantial health system transformation towards primary healthcare, and we are very, very keen to learn about this. Zlate, please, the floor is all yours.
Thank you very much for the nice introduction on what we are actually doing in North Macedonia to provide better healthcare for our citizens just by reforming primary healthcare. And as already mentioned a couple of times here at this webinar, the primary healthcare is the most efficient healthcare that can be delivered, and it's also financial friendly to the system, because politicians love primary healthcare because it's very cheap to be introduced and to be implemented, and also saves a lots of money on the secondary and tertiary level. And it was quite an easy job for us in North Macedonia to convince our Prime Minister, our Ministry of Finance, and our Ministry of Health to go through with the reform of primary healthcare. And I will not delay anymore, and I will start off with what we have done in my country in reforming primary healthcare. So we had 5 strategic goals that we wanted to achieve actually by addressing the universal health coverage. And it was about making primary healthcare a cornerstone in the health system. And we also wanted to make the health system that is more fair and more efficient, especially for the vulnerable groups in North Macedonia, a system that will be financially available, and also for those that cannot afford it, there for them, that will provide certain demands, or will provide for the demands and the needs of the population. We also had to address one within the strategic goal. One of the main problems was the brain drain that of the health workforce. For example, in the past 10 years, we had more than 5,000 doctors leaving the country, North Macedonia, and that was a serious impact for the health system to deliver. And we were also on the daily basis losing a lot of nurses and another profiles of healthcare workers that are very much important for our regular jobs and providing actually healthcare in our country. So we saw also in those strategic goals that the Ministry of Health has to be the leader of the process of implementations of the reforms, and we started building capacities within the Ministry of Health so that reform will be efficiently conducted, and that we will have in the end something that can be an example for other countries to follow. So reforming the primary healthcare actually is something that should encourage the treatment of certain health conditions in primary healthcare that doesn't actually need to be addressed on the more expensive levels in the system that are like the secondary and tertiary care. And when we started off the primary healthcare reform, we started that with the motto that we are planning more prevention, more diagnostic, more treatment, and that will be now more than ever. So from this point now, in the future, we will provide on monthly basis and every year more and more primary healthcare as a solution and somebody who will address the needs of the entire population more than anybody else within the system. So we had the health indicators that show that mortality from the chronic diseases like cardiovascular disease, diabetes, cancer, kidney disease, in our country is about 70% higher than the average in the European region. So the main goal was to start a reform process that is going to improve the quality of the primary health care through a reform of the payment model of the primary health care. We should encourage and ensure the improvement of prevention first and most important, and after that definition and application of standards that will provide quality care for all the citizens, and that will be done by introducing protocols for treatment of the most common NCDs within our country, and also with quality indicators and with clinical pathways for the primary healthcare physician, which is actually the evidence-based medicine which we introduced within this reform. We are also reducing the number on referrals on the secondary and tertiary level, and there is a great number of GPs and the family medicine specialists in the primary healthcare level that now can do more within their scopes and competencies of services that they can provide than they had to do before the reform kicked off. The stakeholders in this process were much important. There were the Ministry of Health, the Directorate of Electronic Health, the Health Insurance Fund, and also the professional association. So what we did is we developed protocols for selected primary healthcare medicine physicians who were mostly addressed as the most common NCDs that were the reason for a visit of a patient within the primary healthcare level. And those were hypertension, diabetes, asthma, COPD, and hypothyroidism. Next thing that we do, we develop the protocols for the gynecologist, for the prenatal care, and also for cervical cancer and for the feminine. We develop protocols for the selected primary care pediatricians for obesity of children and spinal deformities. We also developed and codified the list of interventions that can be provided by the primary healthcare doctors. And the primary healthcare doctors in our country are very much in two diverse groups. In one group, you have the family medicine specialists, and in the other, you have the GPs who don't have the specialization in family medicine. And it's 2/3 of the doctors who are GPs, and only 1/3 are the family medicine specialists. So how do you guarantee quality and good services that will address the needs of the citizens in North Macedonia? It's actually by providing specializations for family medicines that will be free of cost for those doctors, provided by the government, so that they will finish the specialization in family medicine, and everybody on the primary healthcare level will provide primary healthcare services who are actually provided by the specialists in family medicine. We have done amendments due to the relevant laws and bylaws, especially on regime for prescription of drugs. For example, when we did this reform, 3.5 billion drugs that were prescribed for 2000, and we are only a population of 2 million, less than 2 million people, 3.5 billion drugs per year, 2022, were prescribed from the secondary and tertiary level for the patients in Macedonia. Now, those 3.5 billion drugs can be prescribed by the primary healthcare physicians according to protocols that were introduced on the primary healthcare level. We upgraded the software models of My Appointment for code interventions. Also, there are the protocols, as I said, and the forms that can be filled by the selected doctors when they are providing the services. So we have the big data also connected with the protocols and with the list of interventions so that we can analyze where we're lacking something within the system. We address the issue of equipping the primary healthcare physicians with certain equipment, medical equipment that they needed, ECG, ultrasound. Also, we address them with equipping spirometer and etc., something that will provide better services and more services on the primary healthcare level. And most important is the digital part of the reform, where we introduced My Appointment or the electronic health directorate within our country. So we are starting the introduction of a new model that is called smart referrals through the guidelines that will help make decisions about the services that can be improved in coordination with secondary healthcare. We started a new module for the patronage nurses, and also we introduced a new model for the new nurse, which is called the health promotion nurse. And we developed an electronic, we are developing actually at the moment the electronic system for scheduling the visit to the primary healthcare physician, healthcare data. And in the end, what is most important, we are going to introduce the population health reporting tool and introduction. We are also expecting an introduction on the tool for reporting of the quality of services. What we expect from this, the result indicators should be reduction in referral to a healthcare for services that can be performed by the family doctors. And we accept from the baseline of 2023 that reduction to be for 25% compared to the 2023 for the year 2024. And for the year 2025, the reduction is expected to be at least 50% compared to the year 2023 as a baseline. So that is how we actually tried to improve, and I think we have done quite a lot in improving the primary healthcare service within North Macedonia. Thank you very much.
Zlata, thank you so much. And I think I haven't promised too much when I was saying that Macedonia is undergoing a thorough transformation of its health systems. And there are so many ways actually that your reforms are contributing to health security and resilience. Just to pick out a couple of things, the focus on prevention and health promotion. You're putting out a lot of treatment from the hospital to the primary care sector. And of course, with that, you are protecting the hospital sector, you know, if it is really needed. There were efficiency gains, I understand, and there's a lot of data transparency, so you know much better what's going on in your health system. But also you are transforming the health care workforce, and that is probably an aspect which is super, super important from us. And we will hear more about this later in the last aspect, the health care workforce, from our next speaker. So thank you so much, Zlata, for this great input. And I think people will come back during the panel discussion and pick up some of the things you have mentioned during your talk. So it's now my great pleasure to invite Sara to feed us in a little bit on the health workforce developments in Spain, with a particular focus actually on teams and teamwork. Please, Sara, floor is all yours.
Thank you so much for this introduction. Apologies for my voice as well. But yeah, well, during this 5 minutes, I'd like to focus on workforce capacities, as Matthias said, and explore the potential of multidisciplinary teams in primary care for health system resilience. And to illustrate these, I'd like to use the Spanish primary care context as an example and reference a few instances of good practice that we identified in this recently published report case study of the Spanish primary care, developed by WHO in collaboration with an international team of researchers and experts. So highly recommend this document. And well, let me first introduce maybe what the typical composition of a Spanish primary care team, Spanish primary healthcare team may involve. So it typically would include a family doctor, of course, pediatricians as well, nurses, midwives, healthcare assistants, social workers, admin staff, physiotherapists, dentists, pharmacists, a very kind of broad team of professionals, as you can see. Also the, specific, composition of teams vary substantially within and across regions, depending on local needs and policy decisions and priorities. And actually, in recent years, some regions have begun incorporating additional professional roles, such as psychologists, dietitians, or nutritionists as well. Although these are very recent developments whose practical implications haven't been assessed and evaluated entirely yet. But, what we do know is that actually, well, multidisciplinary teams do seem to contribute to enhanced comprehensiveness, as we've heard in the introduction as well, and also the efficient and effective redistribution of primary care responsibilities, right? However, it has also been argued that it can lead to service fragmentation and loss of relationship continuity of care, as there are different professionals attending to different aspects of a patient, and there's no one there to integrate that kind of whole person, generalist, holistic approach that is required. So I would like to bring today a case that I think exemplifies the successful conciliation of this tension. So kind of a fine balance where multidisciplinarity doesn't necessarily compromise relationship continuity of care. And well, this experience, service innovation, was actually identified as an example of good practice by the WHO report that I just mentioned. You can, if we go to the next slide, please. Yeah, so this is, it's called micro teams or family care units. And let me explain a bit what this means. So basically within the wider multidisciplinary team, you've got smaller micro teams within it, and each micro team comprises a named admin staff, nurse and family doctor per shared patient list, whose size typically ranges between 12 to 1,500 patients, right? And this kind of setup in the next slide, please, has shown to, of course, contribute to an effective and tailored patient triage, and also reduce the administrative burden for clinicians, while also preserving that continuity of care, relationship continuity of care, and whole person generalist approach, because there's always a micro team who knows the patient, knows their circumstances and their story, if that makes sense, which is relevant. Now, one of the reasons why this worked is because of the leadership of a GP, Lorenzo Arribas, a very well-known GP in Spain who sadly passed away, and who at some point had sufficient autonomy at practice level to reorganize his team in a very meaningful way, and hence the importance of promoting that autonomy at practice level to encourage bottom-up service innovation and resilience in primary care. This is probably one of the things that I would like to highlight today in this presentation, the importance of autonomy at practice level to boost that service innovation and resilience. And of course, this needs to be complemented as well, right, with policy endorsement and support for this service innovation kind of experiences to become sustainable over time, including appropriate monitoring and evaluation, training and remuneration of this admin staff if they are to assume additional responsibilities and so on. So both bottom-up innovation and of course also higher level policy support for appropriate sustainability. So this is a bit the case that I wanted to bring today. Thank you very much again. I'm happy to follow up with questions in the Q&A session. Thank you very much.
This is so interesting because, 1.5 years ago, we published a huge overview of reviews on teams, and it was crystal clear that palliative care teams, the evidence is very clear, it's very good. But for all other teams, it wasn't so clear cut. And you give us a couple of leads, you know, what might actually contribute to a functioning team. Can I ask you just one thing back? The teams as they are composed, as you have presented, they are very much healthcare teams in a way, even though multidisciplinary. Are they also reaching out to public health?
So you have social workers as part of the team, yeah, and then not necessarily public health within these primary care teams, although you do have some kind of community, in some cases, community intersectoral kind of boards where public health and primary care can come together and work together. Yeah.
Thank you so much, Sara. Very good. Excellent. So great. And now it's time to turn to our next speaker, Tom Rausch from Luxembourg. Tom, we're very keen to hear about communication and trust. Trust is, I think, an issue which has become more and more important. More and more people understand how important it is. Nevertheless, it's sometimes difficult to understand, you know, how you can establish trust. And you share the experience from Luxembourg in generating more trust in the system. So, Tom, please, the floor is all yours.
Thank you very much, Matthias, and also thanks to all the previous presenters for their really insightful presentations. As Matthias just pointed out, I want to touch upon the indispensable role of trust in all sorts of healthcare interventions. And before I look at what we did in Luxembourg, I just want to briefly look at some theory that underlies this all. So a lot of literature has underlined that the success of a public health response hinges on the trust that the responders have been able to cultivate within the communities that they're serving. And along these lines, during the second half of the pandemic, in a policy brief, the WHO also explained that credible, trusted, relevant, timely, accessible, and actionable health information is crucial for the acceptance and adoption of life-saving interventions, which clearly underlines once again the importance of credibility, of trust, and making sure that we establish those before we respond to any sort of situation. However, building trust doesn't just happen overnight. It's a process. It is nuanced, and it demands the attention of a lot of different facets. And one key factor that has been found in a lot of studies actually that plays an important role in all of this is this continuity of care. This continuity allows us to establish a connection, a relationship, and really build a relationship of trust between the caregiver and the care receiver. Of course, there's also a number of other aspects that play an important role. For example, the establishing of an expert identity, or building rapport between the patient and the caregiver, or establishing shared morals. So there's a range of factors, but this factor of continuity of care is really a crucial one. This in turn positions primary care workers in a crucial role, as they often have this continuity with their patients. They see them and they are able to establish a relationship and establish the expert identity and establish a relationship of trust. And these are attributes that are very valuable in outbreak response and also in increasing resilience. If we could move to my second slide, please. Yes, so that's something that we wanted to build on and draw on during the COVID-19 outbreak response here in Luxembourg. We wanted to involve primary healthcare professionals as much as possible. And to do so, we developed a number of communication channels to really keep the primary care workers involved and informed as well as possible. I've listed a few here on this slide, and I just want to talk about them for a couple of minutes. So one of these aspects that we did was we established a direct messaging channel between the health authority and the public health workers, which allowed us to disseminate information and materials as directly as possible and as easily and as quickly as possible. We also developed an ambassador program. In this ambassador program, primary care workers could volunteer to become ambassadors, and they would receive information materials, up-to-date information on a regular basis, but also a type of pin that would allow them to be identifiable in their day-to-day, and so that patients could see, right, this is an ambassador, this is a person who's willing to answer questions, who has information or most up-to-date information. And this was in particular very helpful and valuable during the vaccination campaign, for example. We also developed a newsletter for healthcare workers, providing them with the most recent up-to-date information. And often we also included primary care workers in the writing of the articles within that newsletter. We also organized live Q&A sessions with the general public on social media. And very often we also invited primary care workers to be part of the experts answering the questions in these sessions. That really allowed us to draw on their expertise and draw on their role that they have within the communities. We also organize regular lunch talk webinars, quite similar to the one we're having today, where we would invite primary care workers and all other healthcare workers as well to join us and ask questions, and again receive up-to-date information on the newest findings during the pandemics. And this really allowed us to kind of build up this relationship between the health authority and the people working on the front line in the primary health care. We also put in place a helpline, which was actually geared more towards the general public, where they could call in with questions and receive answers. But we actually found out that some primary care workers also drew on this helpline to receive information, which is a lesson that we learned and we're taking on board for future steps where we may want to look at perhaps putting in place a specific helpline for just primary care workers and healthcare workers in general. So while these were all tools that we put in place during the pandemic, we are still drawing on them now in certain situations, as we aim to maintain and strengthen this relationship and this role of the primary care workers in our system. And we will also want to make sure that we don't need to relearn lessons, redevise tools, and reconnect with the professionals if we ever come into a situation again in the future where we are in a pandemic and an epidemic. So we want to be more resilient and better prepared for such a situation in the future. I'll leave it at that for now, and I'll pass back to you, Matthias.
Tom, thank you so much. I think it became crystal clear that having trust in a situation of crisis, adds so much, to resilience and also to health security for sure. And the way you have presented it, what Luxembourg has done and is continuing to do, actually made it very, very tangible. It's both continuity of care, so that's kind of the material thing, but then also the communication, and apparently you're using multiple channels of communication to reach out to both the health workers but also to the general public. Thank you so much. I think that was a very useful contribution. And now I would like to ask all our speakers to switch on their cameras and their microphones, because my colleague Erika will feed back the questions coming through the chat box. Please don't feel obliged to respond to all of the questions. Just pick the ones out you feel best suited to respond to. Yeah?
Okay, so quick run through of the questions that have been coming in. So to start with, the new roles in the health workforce that came up during the COVID-19 pandemic. Can we have a little bit more detail on the adapting the capacities? Because there's quite a bit of interest on that. But also a more technical question on how we can evaluate the resilience of primary care, or indeed the contribution of primary healthcare to the resilience of health systems. So maybe that's quite a technical question. Maybe that would be a good topic for a future webinar. And also some really big questions. So when you're moving services into the community, how do hospitals respond? Do primary healthcare providers want to take on these services? And indeed, how do the patients respond to being channeled through a different route? So some quite big questions there. So over to you.
Sure, shall we start with Juliane? Juliane, please.
Yeah, I'm just picking up two of them. Leave the others for other speakers. How to evaluate PHC contribution to resilience. I think I mean, there are so many interlinkages and it's a very complex relationship. So I think the way forward is really to evaluate primary care systems, primary healthcare systems in countries. And then, of course, and there are many projects going on especially the Observatory is doing the testing of the resilience of health systems. So I think combining those results, looking at the strength of primary care systems, how far countries have implemented the primary health care principles, the 3 components, I think is a way to evaluate also the contribution of PHC to resilience. And the second question on hospitals, I just want to quickly say that in many countries there are trends and reforms going on that, of course, shift care from hospitals to primary care settings, but also to have a stronger integration of a vertical integration of primary care settings and hospitals. So there are hospitals which are offering beds for patients with who were just discharged from hospitals. So there are kind of ways where primary care and hospitals work together, and I think it's in the interest of hospitals to intervene and as early as possible to keep people and patients healthy and keep them out of the hospitals. So far on these questions, I think there are more to answer from.
Thanks, Juliane. Zlata, can I ask you? I mean, you have described this bold process of your reforms, and of course, a lot of specific treatments are being moved from the hospital sector to primary healthcare now. How do the hospitals react to it, and how do the patients react to it? And maybe can I also continue with this? Tom mentioned that for trust, the continuity of care is super important. You were briefly talking about the pathways, the patient pathways. Is there the continuity strong enough?
Well, actually, yes. The main, the most strategically important question to transforming primary healthcare was actually to provide quality of primary healthcare. And for the citizens, they need to be ensured that the quality of care that they will now receive on primary healthcare level will be as the same quality that they were receiving in the secondary and tertiary or in the hospital sector. And how do you do that? By actually introducing protocols, clinical practice, and indicators of quality, so that you will assure that they will have the same quality care as they did in the hospitals. And the hospital sector will respond by providing support to the primary healthcare physicians in the early stages of the reforms, so that they will have like some kind of backup, like somebody who can tap you on the shoulder and say, okay, I'm here, don't worry about it. If you need any kind of help with this kind of diagnosis or treatment, I will help you out just in the next couple of months, so that you will know what to do exactly at the healthcare level. So the hospital sector has to be very much supportive on how to help the primary healthcare to deliver those services more efficiently and with the same quality as they were delivering them before the primary healthcare.
So it was not a reform against it was not a reform against hospitals. It was very collaborative. But did you need to give them some incentives?
For sure, because the hospitals now will not have to do the basic diagnosis and treatment that can be done by the primary healthcare physicians. And they can focus on their hospital patients who have more severe diagnosis. And it's like shifting only 5 diagnoses. I said hypertension, COPD, asthma, diabetes, and hypothyroidism to the primary healthcare level. Imagine the other diagnoses that you still have at the secondary and tertiary level that you have to be dealing with every day, every week, every month. And there is a lot of responsibility for the hospitals and for the clinical centers to be dealing with the diagnosis in the upcoming future. So it's like hospital sector was saying, thank you for taking away all this burden from us, and we will help you out on providing quality care as a primary healthcare sector in the future, and you will have our full support.
Thank you so much, Zlata. Very interesting, very, very important. Sara, please. You've heard the health workforce is popping up almost everywhere, and there are many questions in regard to it.
Yeah, so maybe in terms of the COVID-19 pandemic and how primary care teams managed, there maybe not so much new roles necessarily. I mean, there were some COVID-19 case managers, but mostly it was a matter of redimensioning teams, by increasing the number of social workers, for instance, in some cases. And also we had very interesting examples of, effective task sharing, role expansion, and so on. So for instance, the role of the admin staff in some cases was enhanced to do appropriate triage of patients, eliminate bureaucracy, and so on. And also the role of nurses and their autonomy in some cases were also kind of enhanced, especially concerning COVID-19 surveillance, contact tracing, follow-up of patients with long-term conditions, coordination with like nursing homes, care homes, and so on. So some of these examples. So I think, yes, I mean, I would say, like the multidisciplinary teams definitely contributed to enhancing resilience by enabling these kind of rapid adaptations and transformations of the system to better cope with the consequences of this terrible pandemic. And I think that the flexibility played a key role, right, to be able to adapt and for the reconfiguration of the teams. And in terms of the other question that I think was asked around how to evaluate this type of interventions or this type of innovations that can promote resilience, I would definitely, probably highlight the importance or key role of complexity-informed, like research approaches that we've been currently developing in my research team. I think there needs to be a focus on how things are worked out in practice, a very clear focus on how things navigate the challenges, mixed methods probably to understand and pay attention to the experiences of frontline workers, the tensions, the barriers, the facilitators they faced, and also outcomes, right? So that kind of integration of methods and methodologies, I think, is key. Mm-hmm.
Sara, can I come back to your first point on the multidisciplinary teams, because you were talking about task sharing and role expansion. And I was wondering if there was a similar effect like Zlata reported from North Macedonia, with the hospitals. Very often certain professional groups and very often medical doctors, they want to cling to their portfolio of tasks and have difficulties to share this. Was it different in Spain, or were they quite happy to be unburdened, or were there some incentives?
Yeah, so I think we need to understand this also in a context of, in a very kind of particular and exceptional context where, of course, everyone wanted to do their best, and there was a very kind of attitude towards dealing with and kind of expanding their roles, sharing tasks effectively and so on, and even assuming additional responsibilities. Now, it also, this COVID pandemic in Spain revealed some shortcomings and system failures. And it has led now to increased dissatisfaction and professional dissatisfaction in primary healthcare, which is a concern. So of course, temporarily, you can definitely assume additional responsibilities, but as Slate also mentioned, that needs to be coupled with more resources and time to assimilate that kind of extra workload that you're expected to handle. And that in the long term hasn't happened necessarily or in all cases. So that's kind of a pending task, I think, that we've got there.
Okay, so still work to do. Thank you so much, Sara, for this. Tom, please.
Yes, thank you. I briefly also want to go back to the point that we've been discussing about moving some services out of the hospitals to primary care. And I think that's something that in Luxembourg is a very important topic as well, not just during the pandemic, but also beyond the pandemic, as we are facing very long waiting periods and a lot of pressure on our hospitals. And it's this shift of services out of the hospital and that's also what Zlata already touched upon, that do not necessarily require hospital care and can be done in primary care, so that we keep our hospitals out of this pressure and they can focus on those cases that really require the specialized care. And one element I wanted to also briefly touch upon is that we haven't really spoken about so far is the role of the pharmacists in all of this system. I think that is also a very key actor in primary care. And it's something that we started to explore during the pandemic as well, where we started including them in the vaccination campaign, which is a task that was not previously done by pharmacists in Luxembourg. I understand that other countries may be doing that already, but that's something that we're thinking about as well, and how to further draw on the expertise that we have in pharmacies and really bringing them into some of the services and tasks that can be done by primary care as well. So that's something I wanted to briefly underline as well.
Tom, thank you so much. I think this is a very common experience that we discover the potential role actually of pharmacists in primary healthcare, and vaccination is one thing, but probably in the future also more monitoring of chronic diseases and roles in health promotion as well. Unfortunately, our time is coming to an end, and that's the moment where I would like to ask Juliane to help me wrapping up the session today. Juliane, please, what do you take out of it?
Thanks, Matthias. Yeah, just a few, 3 or 4 takeaways. I think we saw the complexity of the interrelationship between primary healthcare and resilience. And it's very nicely, Tom showed the importance of building trust, and how primary care is a way and a channel to build trust, because it's providing care in the communities, and it's engaging professionals, but also the citizens. And there are ways to how information can be shared. And of course, the continuity aspect is very important. And secondly, primary care is very important to increase resilience and efficiency of health systems. The hospital play a role there. So keeping patients out of hospitals is less expensive. And primary care is a place for innovations, for driving new changes in health systems, transformation, and workforce is of course one important part of this change and transformation. And lastly, I think the importance of prevention and health promotion came up in the several interventions. So I will leave it up to you, Matthias, to conclude.
Thank you, Juliane. Really great. And I was also very happy about Zlata's comments, on the efficiency, of course, and that it was not so difficult to convince policymakers, because we still need to convince policymakers to invest into health systems. And what you just mentioned, investing in the health workforce, Sara, you said there's still some unfinished business actually in Spain, and it relates to it. And Tom, I think what you did is also quite some investment. So I think this really points in a very interesting direction, very concrete and tangible. And I thank you all for these wonderful contributions. And it's time to close. But again, please remember there will be a WHO conference, the Talent Charter Conference on Trust and Transformation. And I think that many of these topics which you just presented will be picked up in this conference. So thank you so much. Goodbye and take care.